Hi, my name is Sajjad Kazal, and I will be moderating today's session, Stem Cell Transplantation, presented by Dr. Mike Pulsifer from Children's Hospital, Los Angeles. A few announcements before we start. Don't forget to network with colleagues in the chat box at the bottom and utilize the Q&A feature to ask the speaker questions. If you see other questions that you would like to see answered, you can click to vote the question to raise the question on the priority list. Following the lecture, there will be dedicated live Q&A time at the end of the presentation. If you experience any issues viewing this session, please try refreshing your screen or visit the support tab at the top of the screen. Now, I will turn it over to Dr. Pulsifer.
Yep. Thank you. My name is Mike Pulsifer, and it's a privilege to be able to talk to you about cell therapy and stem cell transplantation. I hope I reflect some of my excitement about this field to you, and that I can answer some of your questions and get you ready for your test. This overview is suspiciously exactly the same as the outline that you're going to see in the board's content. Now, the stem cell transplant outline is very different than how we would approach some of the other things that you're going to be doing, because stem cell is an entire field, and we have specific things that we need to get at to educate you about how to handle and think about your patients with stem cell transplantation. So it's a little bit different than taking a disease and doing pathophysiology and moving forward. Instead, I'm going to talk to you about some principles and products associated with stem cell transplantation. I'm going to talk to you about conditioning therapy, a number of complications. Now, infections are going to be covered by a different doc, Sung Young Pai, in another lecture. That's an excellent lecture. And finally, I'm going to talk about indications, but understand that indications are going to be mainly covered in the disease-specific content. I'm going to give a broad overview of indications. So if you want to know when to do transplant for ALL, you're going to have to look at the ALL talk in order to get that. Finally, I'm going to talk about cell therapy. So let's talk a little bit about some key underlying principles with transplantation. First, it's important to understand that you got to know how to collect, process, and store cells, because that's what transplantation is all about. Now, a key here is knowing which cells matter amongst all the cells that we're processing. And I'm going to talk to you about a lot of cells today, but the most important cells that we use to make clinical decisions are CD34 cells, which is a reflection of stem cell content, T cells, B cells, NK cells, and these are the markers that I'll be referring to. And I'm also going to talk about the fact that we use cell numbers in order to choose doses, and that's really important. So it might be nice to fix some of those cell numbers in your brain. Now, bone marrow has been the standard for many years and still is the most common stem cell source used in pediatric transplantation. It's very straightforward. It occurs in the operating room. We take blood via a needle from the posterior iliac crest, a single skin poke, but multiple pokes into the bone in order to remove bone marrow. The other two bone marrow sources that I want you to think carefully about and understand are peripheral blood mononuclear cells. Now, almost everyone calls them peripheral blood stem cells, or PBSC, but both terms are used, or umbilical cord. Peripheral blood stem cells are collected via apheresis, and patients can do this very comfortably, as this patient is doing, just kind of sitting there as her blood is processed and the white cells are removed. Umbilical cord blood is obtained by draining after a placenta is delivered, or even while the placenta is still in a mother, remaining blood from the baby from the placenta. Now, let's talk a little bit about how peripheral blood stem cells are collected, because this takes a little bit of art. It's something that's important to know and understand. Peripheral blood stem cells are collected by doing things to enhance the number of CD34 circulating through our blood. At baseline, you and I have maybe 1 in 10,000, 1 in 100,000 cells of our white cells that are CD34 positive. But by getting chemotherapy alone, we increase that number quite significantly. And when we use GCSF in addition to that, we can markedly increase to the point where you can get maybe 1 or 2% of your cells that are circulating to be CD34 positive cells. So by doing this, we're able to get enough cells circulating through the body that we can collect a meaningful amount that we can infuse into our patients. Now, what you see here is that timing matters, and I'm going to show you a picture that illustrates that. CD34 cell levels above at least 20 per microliter are needed in order to get a good collection. And so we work hard to get there. Now, sometimes our CD34 levels do not rise appropriately, and we have something called a CXCR4 blocker. Plerixafor is the other name for it, which can cause release of those cells from the bone marrow and circulating, but it's timed. In other words, you get release that peaks somewhere between 5 and 11 hours later. So oftentimes you have to give your Plerixafor dose right before bed, or sometimes even very early in the morning for a collection that happens a little bit later that day. Now, this graph illustrates what happens with collection. So you can see here, this is a normal white count. And when you give chemotherapy, your count goes down and then your count returns back to normal. And imagine this curve continuing back where it started. This is your CD34 cells, remember, very low in the blood, and you get a peak. And the key thing here to remember is that peak is short-lived. It's only going to last for a couple of days. So you have to time it just right. You have to test, know your CD34 cells are coming up, collect them right when you should, because if you wait a day or two, your CD34 levels are going to be very low and you won't get the collection you need. Now, once you collect those cells, how do you need to process them? Well, when you do a bone marrow harvest and you have ABO incompatibility, obviously you can't give a red cell filled bag of bone marrow that is incompatible with your patient. So if you have a major ABO incompatibility, you need to do red cell depletion. So this is incredibly important for major mismatches. Now, a challenge with red cell depletion is that you can lose white cells. Sometimes you can lose a lot of white cells, up to a third of white cells, and therefore you oftentimes need to harvest a little bit more than you would otherwise to make up for potential loss when you do your red cell depletion. Now, let's say you have a minor mismatch. That means that the plasma has antibodies that could react to the red cells of the recipient. That's usually not a big problem, but you can get over that by plasma depletion, and many stem cell labs do that. Now, this ABO incompatibility issue is mainly a problem for bone marrow collection. Less of a problem for PBSC, because PBSC generally have very low red cell content, and you measure that content. There are certain amounts of incompatible red cells that you can actually give to your patient, so keep that in mind. And that's known and understood. It's only a small amount, maybe 1 to 2 cc's per kilo, and no more than 25 cc's is generally are the cutoffs that we consider. But bottom line is you can give a small amount. So many times if you have a PBSC product and it has a little bit of red cells in it, you're going to be okay, even if it's ABO incompatible. Let's talk a little bit about cryopreservation. Cryopreservation is very important in autologous collections. We collect peripheral blood stem cells from donors. They need to be cryopreserved. Now, in order to do that, we take those cells and put them in DSMO. What does DSMO do? If you freeze a cell, especially if you put it at a very cold temperature in liquid nitrogen, it is like a plate in a freezer. It can, if you bump it, it can crack, it can break, and that can lead to death. Now, DMSO intercalates into the membrane of those cells, and it causes those cells to be more flexible, and therefore they are less likely to break and fracture during the freezing and thawing processes. So important to have DMSO. Now, a challenge with DMSO is that if patients have room temperature or warmed cells in DMSO at high concentrations, it can be toxic to the cells. So when you thaw, you need to infuse very rapidly. Now, on occasion, so this is used all the time for autologous patients, but on occasion, allogeneic patients will need to have cryopreserved product. Now, the reason for this is when you're going to infuse, you really need to do it within 72 hours preferably, and even more, even better within 48 hours. So let's say, you get a product and your recipient's just not ready. They're too sick to get an infusion. You can cryopreserve that and give it to them later. During COVID, we've had to use cryopreservation often. Now, this has been shown to be okay, and it allows us flexibility with our donors to make sure they're not COVID infected. But it can lead to increased rejection in the case of aplastic anemia. So, okay for cancer right now. Be careful about it for aplastic anemia and maybe other non-malignant conditions. Now, let's talk a little bit more about processing. What other processing steps are needed for bone marrow? Sometimes T cell depletion is needed in order to decrease graft versus host disease risk. Now, there are a couple of major types. There's in vivo T cell depletion. The most established one is CD34 selection, where antibodies that have magnets on them are bound to your collected peripheral blood stem cell product. They go through a column that has a magnet, and all of a sudden, only your CD34 cells that are bound to those antibodies are in that column. You can then wash them out by taking the magnet off, and you've got a very pure T cell depleted CD34 product. The challenge is there aren't any other cells in that, and therefore immune recovery is very slow with those particular patients. The next step in that particular approach of developing this was CD3, CD319 depletion, and now alpha beta CD3, CD19 depletion. This is kind of our latest, greatest. Each one of these series of types of T cell depletion have been an improvement over the last one. They likely give better immune reconstitution, and now alpha beta is used by a lot of groups. There's a new method of in vitro depletion called CD45 RA depletion that's being tested right now as well, and other methods will be coming forward. There are also in vivo approaches to T cell depletion for graft versus host disease prevention. Serotherapy with horse ATG and rabbit ATG can be done. Alemtuzumab or Campath can be given, an anti-CD52 antibody. These can be very effective and very immune suppressive. Post-transplant cyclophosphamide given on day 3 to 4 afterwards also is a good way of knocking down T cells that could lead to graft versus host disease. Now let's talk a little bit about collection of T cells, processing that's necessary to be done with cells. Apheresis of T cells is happening more and more and more for CAR T cells and for other cell therapy that's coming forward. And this is exciting, good stuff. What we do, a couple of hints about this is it's important to try to collect these T cells relatively early on. You want a good high lymphocyte count, and you want the patient not to have been overtreated with excessive amounts of chemotherapy. When those cells are collected, sometimes they undergo further processing with CD4 or CD8 selection. They're then virally transduced and expanded, cryopreserved, and infused. Now, other cells are being collected more and more routinely, so you need to kind of keep this in mind. People are collecting cells in order to expand NK cells, and there are other manipulations that are being done on a routine basis. How do you store these cells? An important thing to keep in mind is that you can transport the cells just cool or with freezer bags, of course, if they're frozen. The shippers that they're sent in are carefully regulated so that you know 100% of the time whether the cool temperature was maintained. The record allows us to see if accidentally the shipper warmed up for a period of time, and those cells may not be viable. In the stem cell lab, of course, they're put into liquid nitrogen tanks, and they can be stored and good for years and years. We watch very carefully over these tanks and make sure that they are appropriate and that no increase in temperature occurs in thaw. Now, I'm going to focus in. There are some cells that we may be talking about in the future, such as expanded iPSCs. But really, let's talk in more detail about our 3 workhorses for transplantation, and that's cord blood, bone marrow, and peripheral blood stem cells. Now, what's best? It's clear for autologous transplant because you get quick engraftment, good immune reconstitution, and have decreased risk of infection, that the only thing to give is PBSCs. I don't think I've done a bone marrow autologous transplant in decades. PBSC is really the way to go. For allogeneic transplant, however, there are risks and benefits to each one. And right now, cord blood, of course, is being given often by many centers. Bone marrow is being given. PBSC is usually reserved only for certain types of transplants, usually reduced intensity. Most of pediatric transplanters know and understand that bone marrow gives good outcomes with a little bit less graft versus host disease. Now, let's talk about comparison about those stem cell sources. If you understand why they're different, then that'll help you really address things. The first thing to keep in mind is, take a look at this. T cells matter. Okay, PBSCs have a lot of T cells, bone marrow is in the middle, cord blood very low. T cell depleted, very low, and haploidentical T cell depleted, very low. And because of that, the time to neutrophil recovery varies, but most importantly, risk of graft rejection changes. If you have few T cells, you're going to have a higher chance of graft rejection. If you have lots of T cells, a low chance of rejection. But risk of graft versus host disease can be very high when you have a lot of T cells versus it being very low when you have few T cells. So take a look at this, and it'll help you understand better the differences between these stem cell sources. Now, your doses of stem cells are going to vary by source. If you're talking about bone marrow and PBSC, our target is to have at least 4 to 8 times 10 to the 6 CD34 cells per kilo. You can go a little bit higher, but we always need to watch the number of T cells. We need to be careful to not increase risk of graft versus host disease. We go higher for haploidentical, as I'll show you below. Cord blood, although 2.5 times 10 to the 7th total nucleated cells per kilo is the kind of lower limit, better outcomes occur with 4 times 10 to the 7th. And if you have highly mismatched donors, you might do better by going even higher. If you have 2 units, if many centers are doing this, you really need to get at least 3 times 10 to the 7th. Now, 2 units aren't being done as often as they were in the past, unless they're part of an expansion protocol, because it leads to more graft versus host disease. But there are a couple of rules here for 2 units with cord blood that you can see. For T cell depleted or haploidentical, there has been good evidence to show that high numbers of CD34 cells make a big difference. So we target much higher. And we also target having low numbers of T cells to be infused. Finally, post-transplant cyclophosphamide has been coming forward. It's used mostly with bone marrow or PBSC. And in that case, here are targets that are desired. Let's give you a case presentation. So you have an 18-month-old child, ALL in second remission. Which would be the best donor for this child? Do you want their cryopreserved cord, an older female who's a 7 of 8 match, a cord blood mismatched at 4 of 6 with this cell dose, an unrelated that's 8 of 8 but only willing to give PBSC, or a cord blood that's fully matched with that cell dose? Well, the answer here is E. Let's tell you why. The child's cord blood, you never would want to do an autologous transplant for an ALL patient. The female donors who are older and mismatched, much less willing to use that one. You've got 2 cord bloods here that you're thinking about, but one has a bunch of mismatches, the other has full match, and therefore it's going to give you a better outcome. And then here you've got a good match, but they're only willing to give you PBSCs when it's really in pediatric transplantation. We really don't like to give unrelated donor PBSCs. Now, let's talk a little bit about HLA. HLA, of course, have class 1 and class 2 that consist of A, B, and C, and in class 2, all the Ds, DR, DP, DQ. They're located in the short arm of chromosome 6. There are many different possible alleles for each one of these. As you can see, over 6,000 for A, B, and C, and in the 1,000 plus range of different alleles for DRs. So how do you ever find a match? We do that by looking at millions and millions of potential donors. Now, if it were just HLA, it would be fine, but there's a lot more to it. There are minor antigens. And we actually want those minor antigens to be there because minor mismatches are what lead to the allogeneic effect that decreases relapse after transplant. These are just a couple of types of minor antigens that are around. And we don't match for minor antigens at all at this point. Now, here's a couple of terms you need to understand about levels of matching. Antigen means protein, and almost no one ever uses it anymore. Almost all the tests that we use nowadays are DNA-based allele level testing. There's a phrase called ARD, or antigen recognition domain. When the DNA testing is done, they really look carefully at the most important parts of the protein, the ones that matter. We don't care about minor problems elsewhere in that particular protein. 6 of 6 means A, B, and DRB1, all the way down to, if you add a C, you're up to 8 of 8. If you add a DQ, you're up to 10. And if you add a DP, you're up to 12. So it's important when you talk about 6 of 6 or 12 to 12 matches to kind of understand what you're looking at. Now, I'm not going to go over this in great detail, but this is a wonderful slide for you to look at. What this helps you understand is by NMDP guidelines, what you look for as the most important thing is resolution of HLA A, B, C, and DRB1 for unrelated donors, standard unrelated donors. It talks about patients who are 8 of 8 matches and 7 of 8 matches, and some things that you can do in order to get the best match possible. But next, the real key thing to look at is donor age. Younger donors are better. This is over and over again shown to be the most important thing in outcome. So what we do when we try to find the best donor is, if you have a donor who's 22 and a donor who's 42, and otherwise they look the same, you're going to take that younger donor. Other things here I won't go into a great deal, but we're now looking at DP mismatches and DQ mismatches, and what's called DR 345 mismatches in order to find the very best matches. I don't think you need to understand that in great detail, but this is a nice thing for you to refer to, and just understand that donor age after HLA is the most important thing. Now, this next slide goes over a lot of cord guidelines for best practices. Again, I'm not going to go into a great deal of detail here. I think the key thing to understand is that you want the best matches you can get. And here are kind of cutoffs about matches that matter the most. This 2.5 times 10 to the 7 cell dose for a single unit, remember, we prefer to have a little bit higher, up to 4 if you can get it. But these are minimum cutoffs that the NMDP recommends. Now let's talk and summarize again some things about donor choice. So first, HLA match is the most important. If you have mismatches, we don't like you to go more than a single mismatch. And if you go more than a single mismatch in the unrelated donor realm, you need to do something else. That doesn't apply, of course, to haplotransplants, which are from family members, which are kind of a different thing. For cord blood, you can go up to 4 of 6 mismatch. A 6 of 7 out of 8 allele match is better, and a high cell dose is better if you have mismatches. Bone marrow is preferred over PBSC. There's very strong data in this, and for sure in non-malignant disorders, you want to avoid PBSC. PBSC results in faster engraftment, but you're going to get more GVHD. And it's used for high-risk procedures, mainly reduced intensity regimens, second transplants, where you really need a GVL effect. Now, let's talk about screening donors. An important thing to keep in mind about pediatric donors is they don't have the true ability to consent. They're not adults for the most part. So we need to figure out how to get assent. And also we need to understand parents are going to be biased. Their sick child is always going to be considered as the one who's really suffering and challenging. And there may be some health problems or some issues or some psychological problems associated with the sibling who's donating that we really need to look at. So it's especially a potential challenge if the recipient has an unknown relationship to the donor has an unknown relationship to the recipient, or there's a difficult relationship to the recipient. And all these things need to be carefully assessed. Um, how do you avoid risks to the donor health? First, you need to look at underlying health conditions. So if a donor has a health condition, for example, if they have diabetes or asthma, those are the most common issues associated with pediatric donors, they really need to be assessed by a specialist to define a risk. And if their specialist feels like they could have general anesthesia and safely undergo a bone marrow procedure, then I think that they oftentimes can be cleared. They also get screened, of course, for a number of diseases and also psychological screens. But keep in mind, pediatric donors, we need to be careful with them because they are not adults, and we need to provide appropriate education and assent. Other considerations. Now, if you have an older donor who's 18, a sibling who's 18, and can provide consent, it's probably a good practice to allow that donor to be first preference. But if your younger sibling is truly a better donor for other reasons, maybe the blood type is the same and the older donor is not, then it's perfectly legitimate and reasonable to use that younger donor. Blood type matching helps and is really great. So if you can get it, but it's not necessary. You can do it without the blood type match. If you have a CMV negative recipient, then it's really great to get a CMV negative donor. Now, positive for positive may also be better. The evidence with that is not quite as strong, but we generally try to give positive CMV donors to positive CMV recipients. A gender match, male or male to female is good, but the biggest challenge is multiparous females. So if you have a female donor who's had more than one pregnancy and an older female donor, then we tend to try to avoid them. We have to be careful about donor recipient size mismatches. The maximum we can take from any donor is 20 mils per kilo. And we like to give at least 7 mils per kilo to a recipient. So sometimes you have to be careful about that. The ideal cord dose you can see here, and one cord is always better than two if you can get away with it with the cords you have available. So then, who's the preferred donor? First choice is a matched sibling. Still first choice, and in spite of the fact that we have really good outcomes with unrelated donors, we still consider matched sibling first choice. Next is fully matched unrelated donor right now, but as I speak, there are multiple retrospective studies and prospective trial now that is testing to see whether haplodonors may be as good or better than fully matched unrelated donors. But for sure, if you do choose an unrelated donor, in pediatrics, bone marrow is the preferred source. For the remaining type of donors to address include mismatched cord, mismatched unrelated donor, and haplo. And as I've mentioned previously, haplos are coming forward. Now there's this in-between group where you might have a sibling who's a single antigen mismatch. Those patients have a similar outcome to a 10 of 10 unrelated donors. So I put them in the same camp as those donors. This is what has been used. And what you can see is that over time, unrelated cord blood has been occurring just a little bit less frequently. And one of the big reasons for this in pediatrics is that there's an increase in haploidentical transplantation that's occurring. With post-transplant cyclophosphamide and alpha beta depletion, many centers are moving toward this and potentially moving away from cord blood. We don't know whether it's a better source than cord blood because they really need to be studied side by side. But this is something that's been happening. Now, here's this picture. I show it every time. Which is a better donor, this twin or this twin? Now, I'll give you a hint. These twins are not identical. They're fraternal, and these twins are identical. So the better donor, if you have an HLA match, is the fraternal twin, not the identical twin. An identical twin would be like giving an auto transplant. And it's exceptionally rare that we would ever want to use an identical twin. as a donor because you want graft versus leukemia. Now, let's talk a little bit about contraindications to transplant. One of the key things to keep in mind is that major increases in risk occur because of pre-transplant conditions. So it's vital for our transplant colleagues to look carefully at every aspect of a patient prior to doing a transplant and make sure that they're in good shape. A transplant is a very difficult procedure, very intense, and in order to undergo it safely, you really need to be in good shape. First, you should not have active infection or inflammation. Even active viral infection can increase your risk of fatal complications. Non-recovery of counts is not a good thing. On occasion, patients go to transplant without having had count recovery. The reason why that's bad is that they have then prolonged neutropenia, which markedly increases their risk of invasive fungal infection when they go into their transplant. Non-remission is also a problem. Always leads to increased risks of transplant-related mortality, and that's likely because of tumor lysis or other issues that occur if you have a fair amount of active disease. MRD positivity still can be done, and transplant can be done successfully, but it does increase relapse risk, and that's an important thing to keep in mind. Comorbidities, though, are what we really look for very carefully. We look at pulmonary problems, hepatic problems, cardiac issues, and renal issues. And you can see some cutoffs that we have for myeloablative transplants here. We really need to make sure that we understand all of the organ function before transplants occur. Patients with poor performance also have bad outcomes. Interestingly, even a difference between 90 and 80 as far as your Karnofsky score or your Lansky score can make a difference in your transplant-related outcome. Now, some of these issues can be addressed by using reduced intensity or reduced toxicity approaches. And that's one of the big things that transplant physicians do nowadays is they adjust their approach to minimize the chance of transplant-related mortality. So what is reduced intensity? So there are three terms that I'll introduce here. You have non-myeloablative. What that means is if you get the prep, you'd have full recovery even though you didn't get stem cell infusion. If you have reduced intensity condition, that means if you get the prep, you may eventually recover or you may not, but it will take a long time to recover. Myeloablative conditioning means you would never recover, your bone marrow failure would be irreversible. Now, let's talk a little bit about what type of preparative regimens are used in different disorders. First thing to keep in mind is that myeloablative approaches in every time when it's been carefully tested have been shown to be superior to reduced intensity approaches, specifically for AML MDS. It hasn't really been tested in ALL, but we definitely for a while thought we could get away with RIC for AML MDS, but we really can't. Myeloablation has been shown to be better because it has less relapse associated with it. The most commonly used regimens for AML and MDS are usually busulfan-based, either Bucy or bufludarabine. Sometimes buthiofludarabine has been used. Increasingly, Europeans are using treosulfan. It's not available in America, but will hopefully be available soon. And this is a good alternative as well. Those are approaches generally aimed at AML and MDS. For ALL, TBI-based regimens have been shown to be markedly better. A prospective randomized trial done through the IBFM showed a decrease in relapse of 21% and a marked increase of overall survival of 16% associated with TBI-based regimens. So right now, TBI-based regimens are the standard of care for ALL. For non-malignant disorder, the preps vary significantly. Some patients will receive reduced intensity approaches, fludarabine, melphalan plus or minus thiotepa for HLH. Bucy is used for a lot. Trioflu is used. Many disorders, though, in the non-malignant category are really difficult to engraft, so it's a challenge. Sickle cell disease, thalassemia can really be a challenge to engraft. So you have to kind of walk a careful line between toxicity. Serotherapy, though, is always added when we have non-malignant disorders. So we're invariably adding either ATG, rabbit ATG, or horse ATG, or CAMPAT in order to decrease graft versus host disease, or using other approaches in order to do this. Now, some disorders require reduced, minimal, or no PrEP, and the classic one, of course, is Fanconi anemia. These patients are highly sensitive to TBI, and we may end up getting either minimal TBI, 300 centigrade, which is about a quarter of the dose that's standard TBI, and much lower doses of cyclophosphamide for Fanconi. SCID, we likely need very little PrEP, and that's actually being tested in a large study right now. And aplastic anemia, of course, we use a much lower PrEPs. Now, this is a nice thing to illustrate a few specific PrEPs in the non-myeloablative, reduced intensity, and myeloablative group, but I want to point out this group in between, reduced toxicity. These are intense regimens that are really myeloablative, but because they are given without multiple chelators, because they're given in a combination that has less toxicity, we call them a reduced toxicity regimen. So you're going to hear that as a term used fairly frequently. Now, our current practice for autologous regimens is a little bit different. All autologous regimens are high dose myeloablative procedures. We really don't have a concept of reduced intensity autologous procedures. The whole point of doing an autologous procedure is to give higher doses of chemotherapy to prevent relapse. And the approaches that have been developed through the year are somewhat disease specific. For example, in the most common autologous approaches, neuroblastoma, CNS, and lymphoma, we use carboatope melphalan or thiocide. The Europeans have been using Bumel, and this has been somewhat introduced into the US. And we do tandem procedures. For CNS tumors, carbo-thiotepa combinations, including tandems of 3 of these in a row, or carbothioetoposide has also been used. Lymphoma, one of the most commonly used ones is something called BEAM, BCNU, etoposide, Ara-C, and melphalan. Now, infections, as I mentioned, are going to be covered by Dr. Pai's lecture. It's an excellent lecture, and I'm sure you'll enjoy this. But I've left this for you to take a peek at. It's a nice kind of overview of when infections occur after transplant. But some key infectious considerations for you to keep in mind are that the transplant approach affects immune recovery. So if you're going to do a cord blood, a T-cell depleted approach, or you're going to use serotherapy, you know you're going to have prolonged immune suppression. So you have to modify. If you're going into transplant with a potential infection, you're going to have to be really cognizant of that. In addition to that, occurrence of acute or chronic GVHD adds to risk, especially if you go over 1 milligram per kilogram of steroids. You really can increase your risk for fungal infections. So all of the complications that I'm going to now review are related to that. So keep that in mind about the relationship of infection to everything else that goes on in the transplant time. Now, let's talk a little bit about partial chimerism, super important thing. Chimerism, as you know, is a measure of how much of a donor's blood is from, of a recipient's blood is from a donor and how much is from them. We now follow chimerism very closely because it matters. So let's ask you a question. You have a non-malignant disorder, a patient with HLH, they get a reduced intensity regimen, and their whole blood chimerism at day 55 has gone from 90% to 50%. So what should you do? Should you wean immune suppression and follow the chimerism, give fludarabine followed by DLI, give a CD34 boost, arrange for a second transplant, or increase immune suppression? Well, the answer is wean immune suppression rapidly and follow the chimerism. The most common thing that you do as a first step in dealing with chimerism is wean immune suppression. Now, let's talk a little bit about that. It's a challenge to know exactly what to do. And one of the things you can do to help manage chimerism is look not at whole blood chimerism, but also at T-cell chimerism. Now, one caveat to T-cell chimerism is that T cell chimerism can be affected by the fact that you do a T cell depleted procedure. And in other words, with true T cell depleted procedure, sometimes you're not going to get T cells for a while. But bottom line is, um, T cell in a chimerism can help, because if your T cell chimerism in a normal T cell replete transplant is rapidly falling, you may be rejecting. In addition, increased T cell chimerism um, from the recipient in malignancies has been associated with relapse. So if you start with a T cell chimerism of 97% and the next time you measure it, it's 90%, then you have an increased risk of potential relapse. So what can you do? Now, there's a lot of things. You can wean immune suppression rapidly. You can consider donor lymphocyte infusion. Those are the key things to keep in mind. With aplastic anemia, though, it's a little bit different. And the reason why is in aplastic anemia, it may very well be that there's still an anti approach from recipient cells, an anti-marrow immune response from recipient cells. So with aplastic anemia, one of the first things we do is actually increase immune suppression before doing anything else. And so that's a little bit different. But for most other disorders, again, you wean and stop immune suppression. If there's no GVHD after the taper, you consider a donor lymphocyte infusion. Okay, let's talk a little bit about graft rejection. Super important thing to cover. Here are the risk factors: non-myeloablative or decreased intensity regimens, mismatched donors, cord blood or haplo simply because of the low number of T cells. Almost all non-malignant disorders, because they haven't received chemotherapy prior to the transplant and they're not slightly immune suppressed like patients who are treated with chemotherapy for malignancies, they have an increased risk of rejection. Definitely hyperinflammatory or hyperproliferative states such as HLH or thalassemia, much more difficult to get a graft in, higher risk of rejection. And of course, infection or viral reactivation, both of those things increase your risk of graft rejection. So here's ways that we approach it. We do less suppression, use PBSC grants for the non-myeloablative groups. We have more of a chance of immune recognition of the recipient by donor-specific antibodies. So we make sure that there are no donor-specific antibodies. We, for cord blood and haploidentical donors, we use intense immunoablative regimens for non-malignant disorders. We use disease-specific approaches, again, to overcome them. For hyperinflammatory disorders, we calm down inflammation and proliferation. And for viral reactivation, we control the infection if at all possible. Now, let me give you a case presentation about this. So you have a 3-year-old who's day plus 16 after a cord blood transplant, just barely engrafted, had a fever to 39.5, skin rash on his trunk, palmar and plantar erythema, pruritus, no stools, normal LFTs, no fluid retention or hypoxia. What do you think this is? Could be, and most likely is, acute graft versus host disease. Acute GVHD usually occurs before day 100. It can occur near the time of the engraftment. Most of the time involves the skin, but doesn't have to. The 3 organs that it involves are intestine, liver, or lung. And it can be a substantial cause of morbidity or mortality. So we've got to be careful about it. This is a classic palmar rash, which can occur with acute GVHD. This is a diffuse rash, which you can see is covering most of the upper part of the body of this individual. It's associated with apoptotic cells in the skin dermis. And when it happens in the intestine, it is associated with significant apoptosis in the basilar crypts. Here are acute GVHD staging. As you can see, skin, liver, and gut can be staged individually, and here are the cutoffs. But overall, acute GVHD grading recognizes the fact that some things are more important. For example, low-grade skin is less important, so that gives you a grade 1. And any stage 2 or 3 liver or gut automatically gets you up to higher grades of graft versus host disease. How do you prevent it? Our most common way of doing GVHD prevention is using calcineurin inhibitors. We need to give some sort of a prevention or everyone will get GVHD. So we are very careful about this. Calcineurin inhibitors include tacrolimus and cyclosporin. And generally, they're given along with methotrexate on day 1 through 6 and maybe 11. And some centers actually use mycophenolate instead of methotrexate, but that does lead to a little bit higher rates of graft versus host disease. Mycophenolate is definitely used along with calcineurin inhibitors for cord, and that has been shown to be very efficacious. Other agents are sometimes used as well. T-cell depletion can also be used. There's the in vivo and ex vivo things that I've mentioned previously for T-cell depletion, and each of these types of depletion have different risks. Now, what if your patient gets GVHD? Our goal, in a way, is to balance, and I wish every patient could get a tiny bit of graft versus host disease, maybe grade 1 to 2, and not beyond that. But we can't always predict that. We instead give an approach that doesn't completely eliminate GVHD risk, but it decreases it. Now, if you have mild disease that's limited to skin rash alone, usually we just optimize your calcineurin inhibitor levels and we give topical steroids. But if you have significant disease, then we will start steroids at 1 to 2 per kilo of prednisolone, try to get it under control. Now, steroid refractory GVHD, which means you have either zero response or progression by 3 days, or no response at all by 7 days, you really need to add more. Ruxolitinib has been approved for children above age 12 who have the steroid-resistant acute GVHD, but other agents can be used as well. And many centers have a number of different approaches that they're using and testing for this highly refractory GVHD. Let's go over a case. We have an 8-year-old child with AML 6 months post-transplant who comes to clinic. He's complaining of a significant rash on his arms and legs, and he has dry, irritated eyes and a persistent cough. His mother noticed he gets winded more quickly than he used to. So what should you do? What's your next investigation that will most likely yield a diagnosis? You want to just send blood for CMV, BAL to rule out pneumocystis, PFTs and a high-resolution CT, galactomannan testing for fungus, or an upper GI endoscopy. The answer here is C. Everything about this kid is suggesting that he has chronic graft versus host disease. And PFTs and a high resolution CT will let you know whether he has lung involvement. Chronic GVHD is diagnosed usually after day 100, but I've seen it, of course, as early as 2 months. It's a significant immune deficiency, and it can have all sorts of manifestations, including skin challenges, vitiligo, or hyperpigmentation, scleroderma. It can lead in some cases to limited joint mobility, sicca, all these other things, but they don't occur at once. It's usually 1 or 2 of these things, sometimes 3 of these things. These are skin lesions that are associated with chronic GVHD. You can see the vitiligo, the hand findings here, and pyroglycocytosis in a typical pattern. When you get chronic GVHD, what happens is it takes time to get patients off immune suppression. With acute GVHD, you can wean immune suppression after stabilization, but with chronic, oftentimes you have flares over, when you taper, and it just takes time. As you can see here, getting the patients off immune suppression can take a few years, and sometimes you can't get all of your patients off immune suppression. Now, what are the risk factors in pediatrics for this? Younger patients do better. Patients with advanced disease do worse, and that's generally because they're higher risk of relapse. Patients with good Karnofsky scores do better. Patients with high platelet counts do better than patients with low platelet counts. And matched sibling recipients, even though they have chronic GVHD, they still do better than all the rest of the stem cell sources. What's standard therapy? The only thing that's really been shown to consistently control and treat GVHD is prednisone, and so that's kind of what people use as a start. But we can't keep patients on prednisone, so we switch to many other different agents. Tacrolimus, sirolimus, cyclosporin. There are a whole list of agents that you can see right here that are routinely used. And we're continuing to work hard to try to find the best ways to approach chronic GVHD. Let's have a case here. 10-year-old undergoes transplantation for CML. The patient is T cell depleted, and on day 145, he develops significant cervical lymphadenopathy and splenomegaly. So, what is the most likely diagnosis? Relapse CML, secondary Hodgkin's, PTLD, toxo, transfusion acquired HIV. The answer is PTLD. Why is that? Got some hints. T cell depleted transplant. And he's still at a point in his transplant where he has very poor immune recovery and he has marked adenopathy. So, almost assuredly, this is PTLD. You'll need to investigate it, but that's what it looked like. So, let's talk about PTLD. So, this is an EBV associated disease that occurs a few months after transplant. It also can occur after solid organ transplantation. It's very highly associated with T cell depletion. So CD34 selection, CD34 selection without CD19 depletion. Interestingly, the important reason for doing the CD19 depletion in those procedures is because that minimizes or decreases the risk of PTLD. Cord blood, especially when ATG has been given, has definitely been associated with it as well. So what's the treatment? Immune suppressive withdrawal, Ritux, cyclophosphamide, all of these things have been used. EBV targeted cytotoxic T cells or viral specific T cells can also be used. Another case, you have a 3-year-old with stage 4 neuroblastoma treated with MIBG, now hospitalized for Bumel transplant. Day 15, getting ready for discharge, all of a sudden you've got abdominal discomfort and swelling, right upper quadrant pain. Your bilirubin increases from 1.5 to 4. Your direct bilirubin is 3.2. There's a little bit of hypoxia and 12% weight gain over baseline. What is this? It is veno-occlusive disease. It typically occurs in the first 14 days after transplant, but it may present late, especially in these unusual neuroblastoma kids. About 25% of patients can be affected somewhat. If you look hard enough for it, you can see a degree of VOD in that percentage of patients who get myeloablative regimens, but it's severe in about 5 to 8%. It's caused by endothelial damage in the hepatic vanules that lead to platelet deposition, hepatic congestion, and cholestasis. Direct associations are with cyclophosphamide, busulfan, and radiation. Sirolimus definitely increases the risk when it's used in combination with tacrolimus and cyclosporin. These are definite signs and symptoms: weight gain, right upper quadrant pain, hyperbiliary, and the rest of these things, including especially platelet refractoriness. How do you take care of it? Key is fluid management. You want to diurese, keep patients fluid negative if you can. One of the chief things is they can become massively fluid overloaded, and that increases intra-abdominal pressure, which just worsens the disease in this kind of vicious cycle. The challenge, though, is to maintain intravascular volume. Many patients are managed with CVVH in order to be able to take off as much fluid as you can while maintaining blood pressure. Defibrotide has been used and FDA approved for this. It's indicated for VOD that leads to any organ dysfunction. The challenge with it is it does increase risk of bleeding, and you have to be very careful to pay attention to the coagulopathy that occurs with VOD, and sometimes defibrotide needs to be held. Here's a case presentation of another complication of transplant. You have a haploidentical transplant for ALL that has GVH prophylaxis with tacrolimus. Have a big drop in your platelet count, worsening creatinine, increased LDH, and a smear shows schistocytes. This is transplant-associated microangiopathy. The pathophysiology is that you get endothelial damage from transplant that can cause thrombosis and fiber deposition in the microcirculation of the kidney, usually. It can also be in other areas. It's been shown to occur in the gut and lungs. This leads to a microangiopathic hemolytic anemia and marked platelet consumption. As mentioned, the kidney is most commonly affected. These are the presenting characteristics: anemia, thrombocytopenia, schistocytes, increased LDH, and decreased haptoglobin. What are associations? Calcineurin inhibitor, especially sirolimus associated with TAC, TBI, high-dose busulfan, and infections. Severe TATMA can be treated with eculizumab, which over time can improve renal function. In addition, consideration of lowering calcineurin inhibitors or stopping them especially if there's a combination of sirolimus plus tacrolimus, has been shown also to help. Another case, you've got a 6-year-old who's out from a TBI-based regimen, comes to the ER with confusion. While in ER, he has a seizure and he can't see. So this is a very classic presentation. If you look at the CT scan showing cerebellar changes of PRES, or posterior reversible encephalopathy syndrome. The symptoms are almost invariably associated with malignant hypertension. This has been linked to calcineurin inhibitors. It generally occurs in the first 100 days after transplant. Patients can have these symptoms that we talked about, and you can diagnose it with an MRI. Now you can see it on the CT, but you see it much better on an MRI. And the treatment is to control hypertension. That's the most important thing by far. Stopping calcineurin inhibitors is generally the first step, but the key is to get their hypertension under control. Let's talk a little bit about late effects after transplant. The worst late effects in all of the reports that occur are associated with chronic GVHD. And some of the most challenging things have been associated with skin, eye, and joint issues, hair thinning, and hypoxia. The most common problem after transplant, though, is relapse. So our goal after transplant is to work hard to prevent that. If you look at non-relapse events, secondary malignancies can occur in somewhere between 2 to 6%. Now, it's much higher in certain types of patients, especially Fanconi anemia patients who have an increased risk of second tumors and other patients who are at risk as well. Growth failure can occur rarely. That has been usually associated with TBI, especially if CNS radiotherapy has been done. Other endocrine issues that can occur include hypothyroidism and gonadal failure. Pre-transplant treatment and graft versus host disease absolutely are associated with late effects. So if you have heart effects after transplant and you haven't had a severe cardiac event, it's almost always associated with radiotherapy exposure to the heart and anthracyclines that you had prior to transplant. GVHD affects the lungs, of course, and can affect the quality of life. And there's some emerging literature to say that TBI has a significant effect on children who are age 3 and below. And because of that, we've tried to minimize TBI in the youngest children. Now, I want to finish up with indications and then talk a little bit about cell therapy. But this is, again, is general. Hematopoietic transplantation is done for 3 things: cancer treatment, resetting a dysfunctional immune system, such as you got marrow failure, you need a new marrow, sickle cell disease, you want to get rid of your bad red cells, or white cell disorders and immune dysregulation. Finally, there are certain disorders, such as mucopolysaccharidosis, where this can be used as a form of gene therapy. The key decision is auto versus allo, and the key here is you give auto for any patient who can benefit from it, because allo is more dangerous. This, though, is limited to a certain number of things, such as relapse lymphoma, neuroblastoma, certain brain tumors, germ cell tumors. Here are indications that are most commonly used for transplantations. As you can see in the other malignant category, a lot of this is the neuroblastoma and other auto patients. You can see a lot of patients are transplanted for aplastic anemia, AML, ALL. As mentioned, transplantation can be a form of gene therapy. This includes patients who have inborn errors in metabolism. The most common and the best data is associated with MPS1 and X-linked adrenoleukodystrophy. So these are the real key ones that we transplant fairly frequently. There are others that can be transplanted, but the best data is for these 2 diseases. The other diseases, metachromatic leukodystrophy. For the other forms of metachromatic leukodystrophy, doesn't work as well. Infantile, Hunter's, epidermolysis bullosa. These are kind of emerging indications. CAR T cells. I think all of you know and understand and have heard about CAR T cells. This is basically taking an engineered antigen, putting it in a T cell. That antigen then targets your cancer cell. It has with it domains that cause rapid expansion and improved killing. The current indication from the FDA is for treatments who have refractory or second relapse. We use autologous cells. These patients can be put into remission almost all the time with the FDA approved tisagene-leqvacil, 80 to 90%. The downside to this, of course, is that 30 to 35% will lose their CARs, and another good percentage will have CD19 positive or CD19 negative relapse, which occurs in the first year. There's an ongoing COG trial trying to see if we can look earlier in the disease process with ALL to see if we can treat it. There's an NHL indication for patients greater than 18, but definitely CAR T cells are highly effective in NHL and adult studies. And there are ongoing studies in AML, solid tumors, and ALL. This is a really nice indication looking at the al-Nafis trial, which was used for the approval of CAR T cells, and the CHOP data showing if you get into remission that about a year later, you have a number of patients who may be cured with the CAR alone. The adverse events that are associated with it are mainly cytokine release syndrome and neurologic events. And there's detailed approaches to how to care for these things that will not be part of the testing that you get. But understand that IL-6 treatment can be used to do this. That's all I have. Best of luck. I am very much excited for the future of transplant. We are going to be doing lots of very exciting cellular therapies, combining those therapies with immune modulator. So I'm hoping to talk to you more in the future about CAR T cells and other great cellular therapies, in addition to transplant in many other indications. Thank you very much for your attention.
Thank you, Dr. Pulsipher, for this excellent presentation. We will now open up the Q&A portion of the event. I believe we had 8 questions already answered in the Q&A box.
Does anyone have live questions? We're more than happy to take your questions.
Yeah, I think there is one question here. In thinking about chimerism, can you help explain again why you increase immunosuppression for patients with aplastic anemia?
Yeah, this is a very unusual situation, and it may apply to other non-malignant disorders, but the way to think of it is this. Aplastic anemia is an autoimmune disease that is mainly caused by T cells that are destroying the bone marrow. And if your chimerism is decreasing, it may be that recipient autoimmune T cells are still destroying the bone marrow and not giving your donor cells a chance to engraft. Therefore, if you increase immune suppression, you calm those T cells down and you give a chance for your donor graft to be stronger and not be rejected. It's a unique situation in that there's an ongoing autoimmune process.
Okay, I think also there is another question. Please clarify DSA on the chart with NMDP guidelines for unrelated donor searches.
Sure. So DSA stands for donor-specific antibodies, and that really applies to patients who are undergoing haploidentical and in some cases cord blood transplant. Patients who may already have an antibody against an HLA type that they're going to receive from a donor. If they have that, that has been highly associated with rejection. So all patients who are going to undergo mismatched transplantation and haploidentical transplantation are screened for donor-specific antibodies, and we do everything we can to not give them an HLA type that they already have an antibody to, because it really sets them up for rejection.
Thank you. Another question. Will you consider avoiding serotherapy, including ATG and CAMPATH and haploidentical transplant given low GVHD?
So that's a very complicated question, but just so you understand, there are some GVHD regimens for haplo that are already designed without serotherapy. Um, One of the challenges that you have with haploidentical transplantation is that it's very hard to get a graft in. And so when the original protocols were designed, serotherapy was put in intentionally to not prevent GVHD, but to decrease the T cells in the recipient so that that it would minimize the chance of rejection. With that in mind, many haploregimens still have that in. We're moving the ATG a little bit earlier. We're making other changes to try to work that out. But I often use a particular regimen that has no ATG associated with it, but it's very immune suppressive and have very good engraftment. So ATG, again, is not used to prevent GVH as much as the T cell depletion processes or the post-transplant cyclophosphamide in that case, but it's used in order to decrease the risk of rejection. So those are the considerations.
Thank you. Is marrow failure due to telomeres biology disorders, example, dyskeratosis congenita, still an indication for transplant?
Absolutely. Dyskeratosis congenita is an exceptionally difficult disease to transplant because they have high lung and liver toxicity. Alkylator-free regimens have recently been developed that can preserve patients long term. But unfortunately, when patients with dyskeratosis congenita have complete marrow failure, they really have no option but to go to transplant, and they can be successfully treated.
Thank you. Could you please expand on allo versus auto transplant indications for Hodgkin's and non-Hodgkin's lymphoma for board purposes?
Yes. I think the important thing to keep in mind for board purposes is that almost all patients who have Hodgkin's or non-Hodgkin's lymphoma who relapse should be considered for auto transplant. Now, there are some exceptions to this that are highly unusual, but bottom line, what the first approach has traditionally been is intense therapy. If they're responsive and you can collect them, then they are often be able to be cured with an auto transplant. The indications for allotransplant for Hodgkin's and non-Hodgkin's lymphoma are unusual and rare. They have to fail their auto. There are certain non-Hodgkin's lymphomas that really don't respond well to auto, but those you don't need to worry about for boards. Just keep in mind that lymphomas are really almost always targeted with auto transplantation rather than allo.
Okay, and would you please be able to clarify minimal necessary cell doses for auto and allo transplant with different stem cell sources?
Sure. Now that's all listed in your slides. So that's what you should really look at. I mean, of course, I know it off the top of my head. With autos, you want at least 2, but preferably up to 5 times 10 to the 6 CD34s. For allos, if it's marrow or unrelated donor, you're wanting 4 to 8 CD34s. For cords, you're wanting preferably greater than 4 times 10 to the 7th TNC per kilo. And for haplos, you give a lot more. You give as many CD34s as you can, and you're really dosing it based on T cells. But look at the materials, because you won't remember the big things I just rattled off. Look at your materials so that you have a general idea of the T cell amounts that are right.
All right, there is another question, I believe it's in the chat box. When will you consider desensitizing or desensitization strategy or antibody reduction strategy in recipients with donor-specific antibodies?
Oh boy, this is advanced and it will not be on the test. I can tell you that for sure. But to answer this quickly, when you have absolutely no other alternative, the first choice, if you have a donor-specific antibody, is to find a different donor that doesn't have that HLA antigen, because you're going to be way better off. But if you must use that donor, it's your only alternative, then you can try various algorithms at reducing donor-specific antibodies, and a number of things have been tried with some success and some failure.
All right, can you please repeat what you said regarding when PBSC is preferred over bone marrow? such as
Sure.
is it preferred in a second transplant or it's never preferred?
Okay. So is one circumstance that is there's really good data to back that up, and that is when you have to do a reduced intensity conditioning regimen. Pediatric patients almost always get myeloablative, very intense regimens because they have better survival. But when they have organ toxicity and when they're getting second transplants, because of those issues and the very high risk of transplant related mortality associated with that, you really want to do a reduced intensity conditioning regimen. Even though the risk of relapse is a little bit higher, the risk of TRM is so high, you want to do reduced intensity regimens. PBSC works better under that circumstance. PBSC may also be considered if you have someone who has an active infection and you need them to engraft very rapidly. But these choices, if you make a choice to get engraftment very rapidly or to get more GVL because you're doing a reduced intensity regimen, that will come at the cost of more chronic GVHD. So if you have a patient who doesn't have those complications, it really in pediatrics is standard to use bone marrow rather than PBSC. Now, that said, sometimes you don't have a choice because you only have one donor and they refuse to give bone marrow. They're only willing to give PBSC. And under those circumstances, we generally will do things like add ATG or other things to try to mitigate the increased risk of graft versus host disease.
Thank you. What is the role of BMT and CGD, both X-linked and autosomal recessive, and also Wiskott-Aldrich syndrome?
Sure, I'll go over that very quickly. So chronic granulomatous disease, um, in almost all cases, I mean, people used to try to do minimal therapies or interferon therapies, et cetera. And bottom line is, it gets you in the end. And we're getting better at transplanting patients with CGD. Those patients, especially if they are having significant complications, all should go to transplant. And there are a number of different, very targeted regimens that can effectively transplant those patients. Wiskott-Aldrich as well. The one thing that we've shown with true Wiskott-Aldrich is that the younger you transplant them, the better. In fact, there was a beautiful publication that the Primary Immunodeficiency Treatment Consortium put out this year, showing that if you transplant them under age 5, then you have a greater than 90% survival rate, and they do exceptionally well. So bottom line is both of these disorders are life-threatening and warrant transplantation in most patients. And so you should consider doing it relatively young before they get too many infections.
Thank you so much. When do you recommend immunization or vaccination following transplant? Will you
Excellent
give
question.
COVID? Yeah, will you give COVID vaccine?
Beautiful questions. So we generally recommend that in allotransplants, you wait until at least 6 months and preferably patients are off immune suppression. That can vary because some may be on immune suppression for a long time, but if they're not off immune suppression by 12 months, we recommend you immunize them anyway, because some patients on lower doses of immune suppression will still respond to immunizations. For autos, we can do them as early as 3 months, but 6 months is also a good time to think about it. Now, will we vaccinate for COVID? Absolutely. COVID's driving us all crazy. And so even though we don't know the right time to vaccinate, most likely transplanters will be using vaccination standards that we've had previously. We all are organizing through the Bone Marrow Transplant Clinical Trials Network a large study to look at COVID vaccination and see its effectiveness in patients who've been treated with CAR T-cell and auto and allo transplant. But yes, we will definitely want to start vaccinating them as soon as we're able.
Thank you so much. Okay, I think we have time for one or two last questions, hopefully. For board purposes, is there any specific indication where you think haploidentical is the preferred alternative donor to go with?
It's a good question. Many people believe that haplo is just as good as any other stem cell source and think that you could use it in any circumstance, but that's being tested. We just got CTEP approval of a study that's randomizing haplo versus unrelated donors, and we're going to be testing that. So it's easy if there's no other donor, no sibling donor, no 8 of 8 unrelated donor. I do haplo above any mismatched donors, and we have excellent outcomes. But yeah, we're studying that in great detail.
Thank you so much. Okay, for board's purposes, would they go into details about picking permissive DP mismatches?
Never. Don't worry about it.
All right.
If
Okay.
you're working with me and we're trying to figure out a donor, I'll talk to you about it.
Okay. Well, I think that is all the time we have. Thank you for attending this session. The chat and the QA have now ended. Please watch for further details regarding virtual office hours in late February and March for an additional opportunity to ask questions and interact with the speaker. Do not forget to join us for the virtual networking social today at 3:30 p.m. Central Time for an opportunity to network with pediatric hematology oncology leaders and mentors, and a chance to receive a $100 Amazon gift card. The next session, myeloproliferative myelodysplastic and histiocytic disorders, will begin at 2:15 Central Time. Please exit this room and join that session's room at the appropriate time. Enjoy the rest of the course. Thank you.
Thank you, everybody. Best of luck.